Good evening, everyone, once again. Welcome to the last session of the program. And as mentioned in the list of topics, this is one of the very important topic that I have included for the program, and that is disclosure of medical error. I think you'll all agree with me that breaking bad news or disclosure of medical errors are difficult conversations, and especially if we are not prepared for it, or if we haven't had any training, it becomes very challenging at times to actually handle such situations. And a lot of aggressive reactions happen once you break the bad news or when you disclose any medical error. So we'll have a role play around this topic, and also have a discussion after the role play and of course presentation. Welcome, Dr. Purnima.
Good evening, ma'am. I'm sorry for the issue that I couldn't join in on time.
That's all right, perfectly all right. Thank you. So we are discussing disclosure of medical error, and these are a couple of topics I had kept for the end because we would only understand them when we have, learned the basics of communication.
True.
And these both the topics require a lot of understanding of human behavior, how people handle grief, how people handle difficult conversation, and what we experience as healthcare providers. All that we are going to discuss in today's session. So the title, instead of giving disclosure of medical error, I've given when things go wrong. This is the title I've given to this topic to be discussed. So if I may ask you, if you were in a flight which had a near miss, a kind of a crash, and some passengers, and including you, were slightly injured in the mishap, what would you like to know, and from whom and when?
Ma'am, I should answer?
Anybody can raise hand and answer. Yeah. Okay, Dr. Abhishek.
I would like to, first of all, know that the airline is concerned about the mishap, concerned about me, and concerned that I have suffered, whatever I have suffered is because of their negligence or whatever that was. And if are they even in the process of making some kind of a compensation? And most importantly, not trying to avert from the truth of what has happened and from their responsibility. So yeah.
Absolutely. So that means if there is a situation where there was something that came up unanticipated, at least there should be somebody to explain, to kind of tell me about what it was. Yes, and then of course you have mentioned a lot of things that you would like to also know. What are they going to do to not let that happen? Thank you. Yes, Dr. Purnima, go ahead, please.
Madam, in the event of an unforeseen catastrophe of which I am a client, I would definitely, first of all, like to know the details of what went wrong.
Mm-hmm.
Was the cause for it? Was it a preventable cause? What are the compensatory actions which are being taken by the company or the airline? Also, that what are the preventive actions they will take not to do this? And I would like somebody responsible to offer their sincere apologies, explanation, and corrective, as well as preventive actions. And I would also, as a client, understand that things do go wrong sometimes. But if it is due to totally preventable error, then I would like to voice my displeasure.
Yeah.
Yes, ma'am.
Thank you. Thank you. I think you also covered almost all the points. So same is the situation when things go wrong when we are working with patients. So when they experience some mishandling or some even complications. So for us, complication is part of the treatment. We know that can happen. But patients, for them, complication is also something that they sometimes consider as an error or something that was not anticipated. So whether it is documented complication or actual error that has happened because of our negligence, they want to know in depth. They want to know what exactly happened and who did it, Why did that happen? What are you going to do to prevent it? And a lot of time, are we really open to talking all this with them? Do we really honestly share those details with patients? Write yes and no in the chat box if you want to answer. I can see heads nodding from left to right and right to left, clearly indicating that no, we are not very comfortable sharing. And that's where the real fight happens. They can sense that something has gone wrong. One, because the patient is definitely bound to experience some consequences of whatever has happened to the patient. Even if it was a no harm kind of a situation or near miss kind of a thing, they can still sense that from our body language, from our reaction, from the way we call our team to come in and to pitch in, they get an idea that something happened. Something was either about to happen or something actually happened and they have been able to manage. And a lot of time when they want to know the truth, I don't think we come out very honestly and openly, in a straightforward manner and tell them this is what exactly happened. So we usually tell what is minimum, what least we can share. And a lot of time we actually cover up things which they can clearly make out that it's a cover. Imagine if you can sense that it's a cover and there is actually something that went wrong or some mismanagement at our end, how would they feel? Or if we were in their position, what will we feel? Will we be okay with that? Will we be fine with that? That is where the real struggle between patient party and us comes in. So I think this session will open our mind to the idea, how do we really go about handling it? Although, in spite of this session, I don't expect people to go out and openly say, okay, this error has happened in your care and we are responsible for it, because I know the consequences. I understand the apprehensions that we all have, that if I go out and openly accept that this is what happened in your care, um, how will the patient party react? We don't know, and how they can become aggressive or violent or destructive. Again, that's something very unpredictable. But at least it will give you an idea. There are situations where you will not be able to avoid explanation. For example, we have had cases where a healthy kidney was removed in place of the kidney that needed to be removed. We have seen cases where patients had unfortunately amputation of the wrong leg. And similar cases, I'm sure you must have seen in your practice or in your experience. So those are situations you can't even cover if you want. You will have to talk. So at least we should know how to handle that. And also, I think understanding how disclosure can help win our patients' trust, and also, will bring down our apprehension of hiding things and not coming out openly. Also will be appreciated, I think, by all of us once we will have this session. So to start with, I think I would like to share some of the cases that I have seen, in day-to-day this thing functioning. I'm sure you will have a lot of cases. But before I go further, any case anybody wants to share where actual error happened, either by you or by any of your colleagues? Don't name the hospital, don't name the doctor, but just tell if you wish to. Yes, Dr. Bijoy, I think you raised your hand, so you can please.
Ma'am, some 10 years back in Pondicherry, I was doing my residency in oncology. I happened to got a case referred from another department with an X-ray. There was a surgical scissor inside that picture in that X-ray. It's a post-operative mishap. So patient was seen for some issue and got operated in a nearby private medical college. And after some 1 or 2 months, patient got some pain abdomen and patient got to the better hospital like Pondicherry, and they worked him up. So this was the case because that time I was so young, even I don't know how to deal with it. I just took the case to my head of the department, and he asked me, don't make a fuss, refer it to that medical college where he has done surgery. I don't know whether it is right or wrong looking back. Actually, he actually don't want to report it and don't want to make it a big fuss. So just keep the X-ray. Ask the patient. There is some complication with the surgery which you have done some 1 month back. See the doctor who have did that surgery and show him this X-ray. I think he will do the needful. With such an advice, my HOD asked me to send the patient to that medical college which he has undergone surgery. So that's how it concluded, because I was not bold enough to check out the remaining part of the story.
So after that, I'm sure you must have not had any idea what exactly happened after the patient. No, I'm sure that I understand. So see, we don't know how to handle, even if we have to come out openly and honestly, how do we go about doing it? And then again, as you said, focus is on covering up, focus is on not, removing the lid because we are too scared to handle the consequences. I agree. Anybody else who would like to share? Thank you, Dr. Bijoy. I think that was a
I would like to share.
sure. Yes,
Again, 10 years back, one of the sister who was on duty in the emergency department, it was a holiday, Sunday probably. So the mother was coming with a child, and the child's age was around 6 to 7 years of boy. Mother was pregnant for the second time. She was coming to take uh, some hormonal injection she was supposed to take. But unfortunately, the child got hurt on the way. He was hit by something, and so the mother advised give a tetanus dose to the child also, the tetanus injection. And the sister, what she did, by mistake interchanged. She gave the hormonal injection to the child and the tetanus to the mother. And only after it was given, then it was realized. So again, just now, Dr. Vijay said, I was quite afraid of what has happened. Why it came to me? Because as a nurse, she had done a mistake, and the report was raised, and apology letter and etc. was to be done from HR point of view. I was fearful enough to find out what was the outcome and how it was being managed, because being a boy getting a hormonal injection related to a lady, I don't know what was the effect of it.
And then how was it managed for the patient? What was done
That's
to?
what, ma'am, I didn't have the courage to find out what happened to the child actually, and how the child is going to, whether the child is going to get affected, because he was already injected with
I
the
understand. Yeah.
hormonal,
So
injection of a lady.
that means they were not informed.
They were informed, madam. So the medical director has taken the steps and everything, and how the patient was called and counseled. Everything was done. But
Okay, but you are not in the know
the,
of it, how exactly things went.
yeah, I didn't have the courage to find out. I only
So
took care of the
whatever had to be done was done, whatever corrective action, or at least informing the
yes,
family
yes,
and asking them to
yes.
come for follow-up and further checkup. So
That was done, madam. My
that
thinking is, what will happen to the
was.
child after maybe 10 years? Will there be any repercussion because he has taken such a injection? That injection had gone in.
So since we don't know what the medicine was, probably we can't comment really how much of the damage it would have actually caused, or was it a irreversible kind of a thing? We don't have any idea about it. Thank you, I think, Anita. That was also a big, great learning for us. See, medication errors are almost like 30-40% of the total errors. Lot of errors happen in medication. It could be prescription error, it could be dosage, wrong route, wrong timing, wrong patient. All those kind of errors are very, very common. And honestly, people don't even report to the patient, especially if it is something like it didn't do any harm to the patient. So why inform? And there is the need to talk about that. So let me take you through some of the cases that I have noted down for all of us. Let me show you the presentation and discuss those cases with you. These are just examples that what we have seen, but I'm sure. Mhm. Sorry. So this is one case I'm sure you must have read in paper where a patient was brought to one of the state-run trauma centers after a car accident, and he was mistaken for another patient who had actually fractured. So this patient underwent surgery for a repair that fracture that he had not sustained. It's only after they actually made the incision they realized, oh, it is not the patient who needs this surgery, and they closed the case. Then in another case, again, this you must have read in newspaper. A 51-year-old physiotherapist was brought to the hospital emergency, and her BP was very high. They were changing in the ECG, but then there was a delay in, actually making a diagnosis and giving treatment on time. And she went into cardiac arrest and she died, right in the emergency. Uh, Again, another case where a 30-year-old woman, she underwent a wrong procedure. She had come complaining minor abdominal pain, but the surgeon mistook this patient for another patient, and then the patient, underwent arteriovenous shunt for dialysis. I'm sure you must have seen a lot of such cases in your practice. Study by Ashish Jha has shown that almost 5.2 million errors happen annually, in India. I feel it is under the underestimation. There must be much, much more than that. So that means a lot of errors are happening around us. Some are reported, some are not reported, and even those that are reported in a very, very, very minimal kind of information is given to the patient that actually looks like that, yes, we have informed, but actually we don't go into the detail. So let's do a small role play because it's very important to see how we actually go about doing it. So we'll take up the same situation of that patient who underwent, surgery for fracture that he did not have. So let's assume that you are the doctor on duty, one of you who has not done the role play, who has not played the role of the doctor. You can, choose to be the doctor. And let there be two family members. We don't need the patient. Assume that patient is in the post-op, and now the family has to be informed that the patient has undergone a surgery that was not required, and you have to inform the family. So I hope all of you have seen the case, and if you want, I can stop sharing this case, and then we discuss it. Okay. So who would volunteer to be the? I don't mind even a non-medical person doing this because again, it should give us an idea of how difficult it is even for the doctors to do this task. They are doing it. They do it because they are supposed to be doing it. So they do it and ultimately it falls on them. But I want all of us to, generate empathy for doctors that it's not easy. It's very, very difficult. So anybody who would be, so I can't see Dr. Soma and Dr. Abdul Razak. If you're there, kindly have your cameras on. This is the last session, so we would like to see everyone. Yes, I request everyone to have your cameras on.
Yes, ma'am.
Thank you.
Yeah.
So, Dr. Razak, we are discussing disclosure of medical error.
Yeah.
The
Yes.
topic of discussion is disclosure of medical. So, who would take the chance to be the doctor on duty? Anybody who wants to try their hand at these? Ravinder, will you be? Okay, great. Thank you. So assume that you are the doctor whose resident or nurse has kind of messed up and has sent you the wrong patient. You just saw the X-ray and you started operating. Although somebody might argue on this that clinically, unless you will see the site, why will you start the surgery? But assume that they have done the draping, they have already prepared the part, so you are just supposed to be doing it. That's what is kind of considered. So who would be the patient's attendant? Somebody who has seen something like this for them or have handled the situation. So somebody who wants to be the patient's attendant. Anandita, will you be?
Yes, ma'am. Yes, sure.
Okay. Anybody who has not done any role play, please raise your hand. Civil, have you done any role play? Unmute.
Yes, ma'am. Yes, ma'am.
Okay, you have done it.
Yeah.
So, any other volunteer? Adandita is one, and the other one. Dr. Bijoy, will you be? Okay. So assume that patient is your brother, and both of you are brother and sister to the patient. Good evening, Dr. Soma.
Good evening, ma'am. I'm sorry, I just now came from a hectic list, so just refreshing joining.
That's what I was surprising at. I said, you never miss the class and you're always, with your camera on. So
No, actually, I sent a message in the chat box. The moment I entered, I switched on and then.
I'm extremely sorry. Somehow I missed.
No worries.
Oh, I'm so sorry.
No worries.
But thank you for informing. Yeah, I did. Yeah. So, okay. So I hope you know the case that we are discussing.
Yeah.
So this is a case where the patient has been operated for a fracture that the patient didn't have. Now the patient has come back to the room. The family has already seen that the leg is already dressed up. They are surprised. The patient never had any injury on the leg, but how come there is a dressing on it? And now, meanwhile, the doctor has called to explain to the family what has happened. So we'll all put our video off, and only Raminder, Dr. Bijoy, and Anandita will be there. And Ravinder, 3 to 5 minutes are okay? 3 minutes?
Yes, ma'am.
Okay. Thank you. Yes.
Okay, we'll start.
Yes.
Okay.
Sure.
Fine. Anindita ji and Mr. Bijoy, please be seated.
Yeah, that's all right, doctor. How come my brother is having a different? How did this happen? Why was he taken to the OT?
I understand your concern. Your
He
brother
just got
had
he got a wound in his hand, and they are planning to do some surgery over his leg. We really don't know what is happening here. Is this a real world? What is this? Why they are preparing his leg to do some surgery? Because the injury is happening on his hand. What kind of service you are providing, doctor?
Yeah, I understand your concern, and I called you to discuss about that only. It is very unfortunate, and we apologize that it was mistaken. He had head injury, and he was to be operated for that. But there was another patient who had to be operated for the fractured leg. It's very sad part on our side that it is your brother who had been taken for the surgery. And
Doctor, I don't take this argument because this is a hospital. You are playing with the life of the patient. Just saying a mere apology, this was a mistake, I think this won't do. Fortunately, we observed it before it is happening. And if something happened after the surgery, if you have proceeded with the surgery, what would have happened? This is the standard of care which your hospital is giving. It is simply not acceptable. We are going to sue you. We are really going to sue you. We are going to call the media persons.
This is very upsetting. Very upsetting.
we understand your concern. I do agree that it is a mistake which should not have happened. We take the complete responsibility of the mistake which is done. Fine. And we will try our best that he recovers fast. We'll take care of that. We feel sorry for what has happened. And though it should not have happened, many times due to certain circumstances, these mistakes are happening.
What kind of an excuse is that, doctor? What circumstances these kind of mistakes do happen? We are not operating a machine. We are talking about the life of a patient. So this kind of explanation, these kind of mistakes do happen. I don't take it. You are not supposed to say like that. Or it came like that. This is normal, or it's such a lame excuse which you are saying. I won't take it. No. Simply, it's not acceptable. These kind of things do happen. Means, what do you mean by that statement?
I agree that this is not acceptable. I agree that it should not happen. But now that it has happened, we are really apologizing for that, and we'll try to do the best for your brother. And we will definitely look into where all the mistakes have happened, and we will try to see that it doesn't happen in future with anybody else. I understand that no hospital should have such type of errors happening. We take complete responsibility of what has happened.
I have something to ask, maybe very common thing. Like before taking the patient to the OT, you must be going through the file, right? How come a patient is totally changed and you have no clue about it, and the surgery had taken place and at no fault of my brother?
There was some mistake, their file got exchanged, and the patient's name was not called. We did not confirm, and in hurry, the operation was done. He was taken to the OT.
I still cannot take this all, whatever reasoning you are giving is not acceptable at all. I think my brother will also agree with me.
Definitely, definitely. We don't want your service anymore. We are going to take the patient out of from this hospital. We will give a better hospital with better responsibility and better care. This is simply not acceptable. Simple. I don't think we need to continue this conversation anymore.
See, right now, he needs
even-
care, and we assure you that what is the best possible care will be provided to your brother, and we'll try to see that the problem that he had come with, that is also taken care of. And we'll try to see how we can compensate. We will look into and we'll discuss with the management also for the compensation which can be done for this. I
Doctor,
understand.
Doctor, you think compensation is enough? The level of suffering that my brother has gone through, you are equating with the amount you are talking about right at this moment? You're talking about compensation. Is it the right time to talk? Did we ever speak to you? We know that your hospital is very highly priced. Did we ever compromise on that? Did we ever stop you from not to do any kind of procedure which is little on the higher costing end? No, na. So don't talk like this because you have done a mistake. That doesn't mean that you will compensate. And you are talking that money can equate my brother's suffering. No.
No, compensation may not be just in the form of,
What kind of compensation that you
financial.
mean, ma'am?
We would like to know what is it that you would like us to say for it.
We don't want. We had come here with a hope that my brother, the treatment will be taken care of properly. It will be taken care of. But I'm sorry. I'm very sorry to say that you didn't take care of, and rather you are asking me what compensation we would like to take.
See,
And we are going to call the media. We are going to call the media.
Yes,
and I want
we
you people
are
to
going
be
to write in the
accountable.
Google review.
Mere apology and keeping on saying the same apology won't do anything. I want the concerned staffs to be called who are all responsible for it. I want to make them accountable.
And a written
I want
apology
those people.
from the management.
I actually need these kind of people are not supposed to work in a hospital where people's lives are at stake. They needs to be removed from this kind of scenario. Let them do some other work. They don't want to work in a hospital setup. Surely I plan to call. I've already called my media friends. They are going to reach here in some time. I want the people involved to be here right now, and they want to explain us. And as a result of this, I want the hospital management to take action and to remove these people from this pause. Let them do some other job.
Also.
I
Yes.
assure you that the necessary action will be taken for the mistake which has happened. But at the same time, if you think of transferring your patient right now, he needs to be stabilized with head injury, and we'll try to do our best possible care that can be given over here.
You're talking about stabilizing the patient. You are almost decided to do surgery to some other parts of the body, and now you're talking about stabilizing. I don't think there is any sense in this. I'm so sorry.
Also, the doctor and the nurse who is involved into this procedure, who has done this gross mistake, misconduct, we would like to take an apology for the same.
We will definitely ask for the apology from both of them, the doctor who has done.
We want the written apology, doctor.
We will take the written apology.
You call them. You call them. We want to know what has happened. You call those people. We just want to know what happened. You call them. We want to know. We want to ask them. Are they sleeping? Were they dreaming? We just want to know. Because we are the people who are concerned.
See, we will call them also and we will talk to them also. We will take apology also from them. Fine. We'll give little time to them also. They are also feeling very bad for what has happened. It is very unfortunate that this has happened, which should not have happened. We understand your feelings.
Ma'am, I think there is a limit for torturing, madam. We'll stop this.
Can I request everyone to come in? Sorry, Raminder, to have put you in that spot.
No,
Yeah,
I know this is the
You did
most difficult
tremendously
one.
well. Seriously, you did tremendously well.
yeah, the time was not passing only.
Yeah,
So
it is
if
one
I
of the
may
most
ask,
difficult situation.
sorry, Raminder, go ahead, please.
I said, yes, it is one of the most difficult situation to deal with when there is such an error happen.
Absolutely, absolutely. So what was the inner conversation, Raminder, that you were experiencing? What was going on inside?
It was that we know that it is a mistake from our side. We know that if we are in their place also, we would have felt the same way. And we often get very aggressive when something wrong happens to our person who has gone for getting the treatment or getting well. So it is difficult. We know that it is a mistake done, but at the same time, that we don't want our own people, like the nursing person and all, to come and face that aggression from the family members. So we need to take care of them also, but at the same time, we need to give the assurance that the best possible care will be provided and it will be taken care
So if it was a real life case, what would have been your major concern?
of. Major concern would have been very difficult to say, but definitely that yes, the mistake has happened, but whatever has happened, at least let us try to see that no further harm is done to the patient.
So I want to ask everyone, how would you handle the demand that call the person, call the person, call the person? I want to see that person. That person must apologize. If you remember, we have discussed this earlier once, that it's not advisable to call the person and
Yesterday, earlier it was told the person should not come in front.
one should avoid bringing them, because one, you don't know how both the parties might react. The person who has even done the mistake could actually become aggressive and start arguing with them. So you would not like that confrontation to happen, and that's why. But then you will have to shift their focus to the patient's welfare rather than saying no, that I will not call. But Raminder handled it very well. Yes, yes, we will call. Yes, yes, we will call. So that was more like politicians' way of doing. Okay, we will call, and when will you call? Nobody knows, and there is no this thing. Okay, so I want to ask others now. What do you think Rabinder did effectively? And even the patient party, what do you think Rabinder did effectively? Yes, Dr. Purnima, go ahead, please.
Madam, first of all, I should congratulate Ramindra ma'am for handling the situation very well. And apparently, the skill sets were very much visible. The first thing is that she followed the general rules of communication. She asked them to sit down. She came clean very well on her own. She didn't. She knew exactly how to handle the balance between disclosure and not commitment. Like Madam, you just pointed out, she didn't commit when and where, but so there was some degree of placation also.
Yeah.
So it was empathy, it was submission of facts, it was placation, and it was also assurance. So all the components of dealing with and this would not be an error, it would be a mistake.
Yeah.
Because it's a mistake, and it is a mistake on basic level of UHID not being there. So it's a very difficult situation to handle. And she did it with all these things that she has soothed them down, she has placated them, she has assured them, and she has also given the scientific fact.
Yeah.
So it was really a very good.
Very well done. Yeah, absolutely. How about others? If anybody wants to add to what Dr. Purnima has mentioned, anything that you think she did effectively and you think that really worked for her? Dr. Bijoy, and Anandita, what do you think Rabinder did that made you calm down? Because you appeared to be, you were just, kind of answering back because I was messaging you. I was asking you to be aggressive. So otherwise you would have calmed by the time Ravinder had completed her exercise. So what do you think she did effectively that did not let you become aggressive?
Ma'am, she was very
calm and
calm. Yes,
She
we
was
both
very
said
calm.
together. She was
Yeah.
very calm.
Okay. What more?
no, we are trying to intimidate her in all possible way. I was trying to get some bone to bite on, but she was not giving any. So kind of pretty much calm and composed, with a lot of grace she was dealing it. I was trying to provoke her. I was trying to ask. I was just trying to cross talk her. Whatever minor point which she was giving away, I was trying to hold on to that. So, but she dealt everything in a very commendable way.
Yeah, absolutely. So I think she offered like Dr. Purnima has actually mentioned everything in step by step that she made them say it, and she admitted right in the beginning that yes, there has been an error and that's a very unfortunate thing. I mean, she didn't try to hide or cover or excuse, and then she did say that we will see whatever best can be done and what action needs to be taken, we will definitely take. So if I may ask Ravinder once again. Ravinder, given a chance to do this role play once again, anything you would like to do differently that you think you should not have done, or maybe you should have done this which you missed because all of a sudden I made you do that role play, so now you have thought over it. Anything that comes
Maybe
to your mind?
sometimes we talk too much about compensation also when we talk about these things that people ask for compensation. Offering compensation was not good, but because that little provoked the family members. That should
Absolutely.
not have been done, and asking it, what action would you like to be taken?
Okay.
Apology.
Absolutely. I think compensation words sometimes don't go, although usually people are happy to know there is some compensation that I can get. But then, I mean, Anandita reacted in a very different manner because if a patient is well off and for them, any amount of compensation cannot compensate for example, the disability it could have caused or the inconvenience it would have caused or damages that would have caused, then this word would have been very, very offensive to them. They must have been very unhappy with something like this. So I agree. Unless they say that you compensate, we should not offer any compensation word. Thank you. Dr. Bijay, you want to say something? Okay, okay. Anything else? Anybody else you think something that should have been avoided or this is not helpful? I think 2 points I had noted. One is, of course, Ravinder, you have talked about that don't offer compensation till they ask for it. That is one thing. And second, when you try to explain them and justify your mistake, then they become very upset. When you say sometimes in a hospital setup like this, things can go this way, they feel very bad. They say, I mean, it is not taken well. So I think that kind of justification, accepting that yes, the error has happened, we take the responsibility. We will definitely take full, whatever steps needs to be taken to minimize the damage and also to prevent this error from happening again. That is okay. But this justification, this is not a big thing. See, no harm happened to your patient actually. It was a surgery, no harm happened to your patient. We just opened and then we stitched it and we have dressed up. So again, this kind of an apology will not work. That no harm. So were you waiting for some harm to happen? They will ask you this. So I think these are a couple of things that you actually, especially the composition word literally went into argument with the patient party. It misfired actually. It
I
misfired.
could make out that, that I should not have talked. As soon as they reacted, I
Yeah,
could make out.
absolutely. So these were the 2 points. Any other point if somebody wants to highlight? From the observer side, from the patient party side? Okay. Disclosure of medical error is very challenging. Even very seasoned clinicians find it very difficult to do it. So, anybody who would like to share their experience where they have done the disclosure of error before I go further into the presentation? Dr. Som, if you would like to share any experience where not only by you, by your one of your junior who did a mistake, or if it is not even a mistake, for patients, even complication is something that they were not anticipating. So, if you would like to share your experience.
I have had lots of experiences.
Just share one for everyone.
Yeah, so I'm just wondering which one to share since it's
Yeah.
being relayed live. So, yeah, maybe around 10, 15 years ago, there was an incident. Like we have in anesthesia, the medical errors or the errors happen most of the times due to medication errors. More than 50% of errors are due to medication errors. So there was a patient who came for a surgery, and then injection ranitidine, which is supposed to be which is an anti-ulcer medication. So injection ranitidine was supposed to give an IV. So one of the I graduated, and then I joined as a lecturer in a place immediately after I graduated. So one of my postgraduates had instructions to give ranitidine. So he loaded the ranitidine, talking over phone, and then gave it to the patient. And then the patient started having tachyarrhythmias. So we have some error called as look-alike, sound-alike drugs. So it is a look-alike medication error. That is the injection ranitidine, the ampule looks like injection adrenaline. So the adrenaline was injected inadvertently than ranitidine. Fortunately, the patient was a very young patient, 20-year-old male without any comorbid conditions. And the patient had a severe tightness in the chest, and then severe tachycardia, sweating. And since the adrenaline is a short-acting one, all these effects subsided in the next 10 minutes. Fortunately, there was no aftermath of the patient. And then I was called for help after ranitidine was given and this event has happened. And the PG couldn't identify the mistake. He thought that it isn't something anaphylaxis to ranitidine is happening, and he was afraid a lot. And throughout this problem, it was a government hospital setting. So the patient's relative was sitting standing nearby, watching all the drama that's unfolding in front of him. He became so wild, and he was asking, why did you give this medicine? What happened to my, actually it was a son. So what happened to my son? He's having lots of sweating. He's holding his chest. Did you give any wrong medicine that has caused a cardiac event? Did my son undergone a heart attack because of it? Now it was a tricky situation because the patient was very visibly angry, the patient's father. Because any as a parent, a 20-year-old son is getting a wrong medication that can, and if he comes to know that it is an adrenaline that can lead to serious adverse events, anyone will be angry, aggressive. He started becoming so aggressive and violent. And then the one thing I did was I asked the postgraduate to go into a nearby room. It's a double door entry theater, the theater has. So I asked him to go out to the theater. And that postgraduate was so conscientious that he wanted to stay with the patient to monitor so that nothing wrong will happen. And I was worried that something inadvertently will happen. So I sent him, you go and go through that door, go to 6th floor and call HOD madam, she will come. So just inform her what has happened and call her so that we can sit and talk about it, how to go about it. And then once he had gone, then the father had seen that the guy is going because he knows that he was the one who gave the injection. So he's asking me, that guy had done something wrong and you are protecting him and you are sending him away. I told him, no, this is an internal issue. We will definitely take it up at the departmental level. I'm escalating this issue to my senior person so that she will come and help us out if there is any issue. And then by the time my HOD madam was coming down from her theater, I started keeping him in oxygen, took a 12 ECG, sent for cardiac markers, and all these the necessary steps to prevent, to diagnose if any further complications arise. And then I was freshly graduated, so I was really clueless how to talk to him. So I ordered a battery of tests, called up the staff nurse, made one staff nurse to sit by the patient to monitor, and gave a piece of paper to document the pulse, BP, vitals in every minute so that nothing will go wrong. So that guy was impressed that, okay, there's some error has happened, and then they are taking all the necessary steps so that further damage will not occur. So he was very, he was started calming down. And my HOD madam, she was very elderly lady. She was very excellent communicator. She came and told him, "Come, let's go to my room and then talk." So he told, your brother is, your son is very safe with this doctor. And then he left me and with the staff nurse. And then she told, and then on the way back, she sent a message to join me in the room in the next 5 minutes. And then I entered her room, and then she made him to sit, and then told him, see, such an error has happened. We call this as a medication error. I apologize for the error that has happened. As a responsible head of the department, it is my responsibility to oversee. So some error has happened. I am responsible for this event. And a drug has to be given. Instead of that, another drug has been given. And fortunately, no harm has been done to the patient. And still, we will do all evaluations so that your son is safe with us without any problem. I will make sure that he will be in ICU for next 24 hours so that he will be monitored continuously. And then we will discharge him after he's supposed to undergo a surgery. So his surgery will be cancelled as of today, and he will be put on list tomorrow as the first case. And then he will undergo surgery. Then again, I think she would have apologized some 6-7 times during the course of conversation. I take responsibility for my team's mistake. I will make sure that things will go wrong, things will go right, and everything. And at the end, she told, "What other things can I do for you? What questions do you have?" So the father was very happy that very senior professor had come down from 6th floor to 2nd floor OT and apologizing, taking care of, and taking to her chamber to apologize, and also made sure that for the necessary steps has been done. And also, instead of blaming someone, the hospital or system, she took the blame on herself. And at the end of the conversation, she asked, "What else do you need, or what can I do more for you?" So I felt that was an inspiring moment for me to learn, so that I can have a good conversation with such tricky situations. As a novice, I was totally clueless. Probably I would not have handled with such an elan that my HOD has handled some 15 years ago. So that was really an eye-opener for me. So that's one experience I can.
Yeah. Thank you so much. I think this whole description has actually summed up the presentation that I'm going to share with everyone. And fortunately, if you had a learning under her how to handle such conversations, I'm sure you would have learned the finer details of what should be your way of handling those things, and also your body language and non-verbal communication. And that's what exactly we are hoping, that everybody learns how to handle these situations, because it's not always seniors who will come to your help. It will be sometimes you have to handle the situation. And trust me, I have had I've seen so many such episodes where people do not know how to communicate, and then they create a mess of the whole situation. I am reminded of one case where a lady had amniotic fluid embolism. Unfortunately, she had a stillbirth, a male child, first baby, and immediately after that, she went into amniotic fluid embolism. And the mother had to be moved to a tertiary care hospital because it was a small nursing home where she had, delivered the child. And after the lady was moved to the other hospital, unfortunately, the staff from the hospital calls the family of this lady to come and collect the dead body of the baby, because we have no way to keep this baby, and then we have cats and dogs around, so we can't keep the paper. So imagine what would have been the reaction of the family. See, that's the moment where we have to speak very, very carefully. We have to choose right words. behave in a right manner, tone of voice, everything has to be perfect. Only then you can handle such situations. Otherwise, I think I shared another case where a boy met with a road traffic accident. I think I shared with all of you, where the medical superintendent, he said that boy who had to undergo, who had to undergo postmortem, the medical superintendent says, "Mitti hai, chahe aaj karwa lo, chahe kal karwa lo." You remember that case? So it is not that it is seniors or juniors who know or who do not know. Each one of us has to learn it, how to go about it. I think the whole idea of this discussion is that we have to learn to become comfortable talking difficult uh, issues and difficult concerns. So let me take you to the presentation once again and briefly explain the protocol of how do you go about doing it. So this is the case that you have taken, and you have seen how difficult it is to actually handle the situation. We have talked about this, so I'm not talking further on this. I'm sure you all observed how Raminder played the role, and what are the concerns of the family, and also for all of us to observe in the whole role play. So I just skip these slides and we'll move further. Okay. So as I said, even very seasoned doctors find it very uncomfortable and distressing to communicate medical errors. Why? Why? Write in the chat box. What do you think are their reasons why do they find it difficult to communicate? Write in the chat box, please. Absolutely. I think fear of litigation, physical violence, and of course, lack of training because we don't know how to handle it. Yes, I agree with you, Dr. So, yes, it will bring down the image of the institution and also oneself, also, isn't it? Because ultimately, you will be called a bad doctor, with bad reputation. So, yes, accepting the fault is very difficult. I agree, Chenna, because that's not easy to say, yes, this has happened because of me, or I have done this mistake. So we try to beat around the bush. Agree. Absolutely. What do others say? Okay, will be named, shamed, and blamed, especially in modern media coverage. Absolutely. I think named, shamed, and blamed is a good this thing rhyme. To fear about aggressiveness coming from the patient party. Yes. Feel guilty. Yes, that's also one of the concerns. Facing the situation is difficult because sometimes we don't know how to go about doing it. Yes. To fear about aggressive reaction, yes, absolutely. Then fear of losing patient trust, absolutely, because patient will not believe you or your hospital, and they will not stick to you. They will not stay with you. Absolutely. So usually, yes, litigation is another common fear that comes to our mind, where we fear that there will be a legal case, or I'll be kind of, in trouble because of that. Absolutely, I think so. Definitely, one feels okay. Difficult to accept, acknowledge, and tell that I have made an error. Absolutely, that means again we are too shy of admitting that I could also make a mistake. Absolutely, punishment or termination. That's also one of the, and also a lot of compensation sometimes is rewarded by the court. So that also becomes a fear that it is not just the litigation, but also ultimately I'll have to pay for and that is, I think the fear of that is pushing people to go for indemnity coverage because they want to be saved of that. Absolutely. Losing registration to practice, that's also one of the reasons, definitely, because in case if the error is so gross that you can also lose your license. Absolutely. So as mentioned by all of you, it causes a lot of embarrassment, then aggressive reaction, risk of litigation, and all that. So that's the reason why most of the people focus on covering up rather than actually coming out with it. So let's understand a couple of definitions, what we think about medical error, and then what patients think is medical error, and that will tell us how people view the same situation differently. So if we talk about the definition of medical error, I think we all know that it's a failure to complete an action that we are supposed to do, or using a wrong plan. for the treatment. It may or may not result in adverse outcome, but error is an error, whether a harm has happened or not has happened. Complications, of course, we all know that it is something that was, that is already well known, and it is an unsuspected medical condition that arises during the treatment. So it's usually documented, so we know that this is one of the possibilities of a treatment or a condition. Omission, of course, that is when you miss to do something or neglect of duty. And unanticipated outcome is where the results differ significantly from what was anticipated. So this is usually the understanding we all have about the medical error and complication. Now look at how patients view it. For example, from patient's point of view, the definition of error is very broad. They include even things that are non-preventable. For example, complication, even that is seen as an error. Even poor service quality is considered an error. When we fail to communicate, even that is taken as error from their point of view. Whereas for us, the definition of error is very narrow, and we only consider error if we have deviated from the accepted standard of care. Now, expectation of disclosure, patients expect disclosure of everything, whether it has caused harm or it has not caused harm, or if it was even a near miss. Whereas on the other side, we believe that we should communicate errors only that has done any significant harm to the patient. Now, coming to how the disclosure should happen, patients expect us to be doing disclosure of error truthfully and compassionately. Whereas for us, sometimes we want to give only minimal disclosure, and also at times we do it in a more mechanical manner where we just talk about the facts and not taking any responsibility. So when to have the conversation, patients want it to be done as soon as possible, whereas the physicians want to do it when they have all the facts, because they want to be very sure of everything before they share the information, and from that also the minimum information. Coming to the role of apology, patients expect apology. And if you saw, every time Raminder said, "I'm sorry for this has happened," we could see a change on Bijoy's and Anandita's expression, because they were like disarmed in a manner. Whereas normally we don't take apologies in reality and in real life situation, because we think if I apologize, that means I'm taking responsibility, and then it creates liability on me. And also patients, the healthcare providers fear that this is something like, this can go against me, in the court of law. Now coming to what do patients expect? So when patients, get to know about any disclosure, what do you think, error, what do you think they expect? What are their expectations? Write in the chat box, please. What do patients expect? Absolutely. Apology. That's one thing they always expect. Yes. Actions. Ownership. Explanation. Explanation, ownership, apology, action taken. Absolutely. Acknowledgement of their distress. Yes, that's also one of their concerns. Compensation. Yeah, they ask for compensation. Absolutely. So some of you are messaging me directly, so others are not able to read your message. If you change the setting, then your message will be read by everyone. Truth of what happened, action taken, compensation, and further medical care, and especially if it is going to cause any monetary burden to the patient or patient family, that needs to be looked after by the hospital, because they feel that was not their fault. It is the hospital's fault, so they should be looking after. So I think, first of all, they want statement that error has occurred. So that's one thing and more we try to cover up, more we try to avoid that, more we try to explain in different ways, more they will push on. Tell me clearly, was an error, did any error happen? Was some mistake, done by any of your employees? So that's one thing they first of all want to do. Then, of course, they want to know the details of what happened. They want full disclosure of whatever has happened to the patient and implication to their health. How is that going to affect them now or later or their future? Then who is responsible for this? Because as of now, if that image is blank, they want to put a face there to know who is responsible for it. So they would normally want to know who has done this and who is responsible for this, and also why it happened. So they want to know the reason why did that happen? How could you make that mistake? So like when you said their case sheets got exchanged, so they get an idea. Okay, that was the reason why my patient was operated instead of another patient. And then of course they want to know how will reoccurrence be prevented. And then of course, as many of you have written, apology. So this is what usually patient party expects from us. And when we don't, work on these or avoid anything, they insist on understanding these things. So when we talk about the disclosure gap, 90% of the doctors support the principle of disclosure. But studies suggest not more than 1/3 of the doctors actually disclose in an honest manner. So you can well imagine what is the huge gap. Studies suggest that 2/3 of the errors are not reported. I think you will agree with me. At the same time, even if disclosure happens, it does not meet the patient's expectation because we do it in a very superficial manner or the minimum, information manner. And one of the major reasons is that ladies often do not learn to disclose. So definitely, there is a hesitation to disclose. There's a unlikelihood of disclosing. So, by the way, why don't we disclose? Why don't we disclose? You have already mentioned a lot of reasons in the previous. Anything other than that? Anything other than that? Why don't we disclose?
Ma'am, may I?
You'd like to speak and say?
Yes.
Okay. Yes, go ahead, please.
Which we have not acknowledged till now is that, or not spoken about in our discussion, is that often the mistake is inadvertently happens. It's not intentional, more often than not. And the person at whose hands the mistake has occurred is also going through a lot of trauma and is trying to accept and is trying to deal with it. So is in a state of emotional confusion. And another point I would like to add is that if we have a conversation between the transparent conversation and admission and apology, we should also address it again with a follow-up session is what I humbly submit. Is because it takes people time to process emotions and process events. Thank you, ma'am.
Yeah, thank you. So I think the concept of second victim now is really catching up. People are understanding that anybody who has made a mistake or whose patient has had some complication or has deteriorated, the treating healthcare provider is equally affected inside. So they are also overwhelmed with feeling of failure or not being, doing good, and self-doubt. Those things definitely come in, and they also require support and counseling and help from the hospital. And I think this is really catching up fast. Yes. Sorry, Raminda, you were saying something. Please go ahead.
Yeah, just one more reason can be that many times they feel that if you don't tell, maybe that the patient or the family members will not come to know that some error has happened.
Absolutely. I think you're very right. A lot of times we think that uh, we are skeptical of the benefits and believe that disclosure is unnecessary. So we think it's not required, especially if we have been able to undo or if we have been able to take corrective action. So we feel there is no need to do it. It will unnecessarily distress the patient or family. Sometimes we think like this, and therefore we don't want to share. Also, if the patient party is unlikely to find out, again we feel what is the need to tell? We have already done the corrective action, but there is a need to tell them and put them under any kind of distress. Of course, as mentioned by a lot of you, fear of retribution from patient and colleagues. We fear that we will be labeled as irresponsible or careless or not, proactive. Legal action and financial judgment are, of course, definitely a concern whereby we don't want to disclose. Then fear of to handle patient's emotion. Especially we know a lot of time the patient's party or patient himself or herself can become aggressive for what has happened and can lose their control. So we fear how will we handle those emotions. Also, sometimes we believe that the disclosure is primarily a factual conversation and not a complex, interpersonal conversation. So therefore, at times we do it in a very mechanical manner. That itself can sound like not doing it in a very responsible way. Also, sometimes we believe that the outcome is not related to action on the part of the person disclosing it, especially if you are not the one who has done it, but somebody has done it, but you are supposed to be doing the sharing of information. So you may not do it in a very great manner. And of course, we all know there is lack of training in error disclosure. So people do not know how to go about doing it. So they try to avoid disclosing it to the patient part. If we disclose, what do you think are the benefits of disclosure? Write in the chat box. Although I know as of now we are not very, very open to disclosing, but if we disclosed, how do you think we will be benefited? Ultimately, how will that benefit?
Ma'am, can't hear you. If we disclose, how do you think?
We will be benefited. What is the benefit of disclosure?
Acha.
Yeah. It helps in reassuring, in this word is difficult for me to understand. Dr. Abhishek, you'll have to explain. Is it something like we will not feel guilty? We'll come clean?
Yes. It will help in sort of dealing with our own guilt, because we all will be feeling guilt.
Yeah.
So at least we have done this bit.
Yeah. So you'll feel clean. You'll feel that you have done your job. Great.
Yes.
Thank you. Yeah. Of course, patient treatment will be at the timely treatment will be done. Jenna has mentioned honesty of the team. Yes, it actually shows that you are honest. Then being transparent with clear guilt, that means no guilt, reduces the likelihood that the patient will sue the doctor. Yes, I agree completely. When you come out open, usually they give up the idea of suing the doctor or the hospital for negligence. Patient treatment does not suffer. Patient will be saved. I agree. Whatever treatment needs to be done, if that can be done freely, and I mean, either by you or by any tertiary care hospital or different hospital, definitely patient can be not only saved but can be helped. Absolutely. And then it puts the patient's mind to ease. 1 second, I can see some more answers. It helps the team to find out root cause and correct and prevent error. Absolutely. Unless you will admit that yes, an error has happened, you will not take any corrective action or preventive action. So it's always good to let others know that this has happened so that that error can be managed and can be prevented in future. Further management on time. Absolutely. Have I missed any answers? Relationship between patient and doctor will improve. Absolutely. I think trust will be, reinstated. Yes. Peace of mind. Yes, you will be calm and you will be honestly feeling honest that I have shared my feelings or thoughts. Absolutely. Patient will be tipped. I hope I have not missed any point. Okay. So definitely if we disclose, trust and communication between us and the patient party will enhance. They will believe that you have come out honestly and openly. So that means they can trust you. As mentioned by all of you, patient safety will be ensured. Whatever corrective action needs to be taken, whatever needs to be done will be done. Informing the patient party and taking corrective action. And then, of course, ethical and legal obligation. We all are supposed to be legally disclosing the error to the patient party, and if you are doing it, we are actually following the law. And of course, it will bring in quality improvement, because every time error happens, and if we go into root cause and we take corrective action and a preventive action, automatically those errors will slowly go down, and it will improve the quality of the care. Absolutely. Studies also say that only 3% of the patients actually sue the doctors or the hospital. Most of the patients and their family members are okay when you explain them in detail and when you talk to them. But it's our fear that prevents us from, talking to them freely about their whatever has happened. Usually, patients sue when they see that some information is not being communicated effectively, or they sense a kind of a lack of empathy and feeling of being mistreated. Also, if they perceive, or actually if we are withholding some essential information, they feel very, frustrated, and out of anger, they want to sue the hospital. Studies have shown that it is not negligence. In almost two-thirds of the cases, it is not negligence, it is actually ineffective communication that leads to patient party, ultimately deciding to sue the hospital or the doctor. So there are a lot of studies when you will look for that have where the hospitals have adopted disclosure policies and they have shown the benefit of full disclosure. So this is one study I found interesting and I thought I'll share with you. This is a full disclosure policy implemented at the University of Michigan in 2002. So three components that they worked on. The first one was if a patient was harmed, they acknowledged it and they compensated these patients quickly and fairly, because they did not try to cover up, they did not waste any time, they just spoke to the family, informed them, and they took a quick action in resolving the case. Second was if they felt there was no error, then they aggressively defended the case in the court because they knew that they are not at fault. So even if the family decided to sue them, they didn't mind going to the court and defending them. And third, if there was any adverse event, they studied how to avoid those errors in future. So they worked extensively on improving the service. So they did a comparison between 2001 and 2005, if I'm not wrong. Yeah. So you can see their annual litigation cost almost went down to 1/3, from 3 million to $1 million from 2001 to 2005. Even their average time to resolve those cases of claims and lawsuits went down to almost like 40%. And also the number of complaints and lawsuits also, went down to almost 40 to 45%. So this study and many more such studies help us understand that if we learn how to do it properly, of course, we need to follow all the previous conditions thoroughly, where we keep them updated, we keep them informed, we let them know, we answer their concerns, we meet their communication and information need. And then when there's an error or some kind of complication, and if we timely, in a professional manner, we explain to them, usually family ultimately accepts and they're ready to work with us as a team. So I'm going to share guidelines. Again, these are just guidelines and you can design your own way of doing it. But these guidelines help us to go step by step in working on a situation like this. So the first step is always preparation, that we need to first of all check in how ready I am. Am I okay? Am I feeling overwhelmed? Am I upset? So whatever it is, you have to really calm down because you need to talk to the family. So know about the patient, know about the patient's family, who all are there, who are the primary caretakers. So that will kind of give you a picture of how do you go about doing it. So review all available medical facts because patient family might ask you more details. And if you fumble, if you don't know, if you're not sure, it will further cause confusion, and they will lack trust in you, lose trust in you. So make sure that you read all the medical facts, that the family might ask you. You can also take assistance from your trusted colleagues. You can ask them to join you or be there when you are doing it, or you can discuss with them how you're going to do, the disclosure. Then please prepare yourself for strong emotions because family might react, and even you are going to kind of experience, feel overwhelmed. So it's very important to be ready to handle emotion. Second is, of course, perform when you sit and talk to the patient's family. So make sure that you begin by stating that there has been an error. I think when you start with this, you already have disarmed them of all kind of anger and aggression they would have otherwise come out with, just to make you say yes, an error has happened. Of course, then describe the course of events using simple and non-technical language. What exactly happened and how it happened. State the nature of the mistake, consequences, and corrective action. So, what exactly happened, how it happened, what is the consequences, and what corrective actions you have taken to minimize the damage. When you are explaining all this, make sure that you use frequent pause, because they may want to ask you something, they may want to say something, they may take time to even absorb what you are saying. And also, if they have questions to ask, you will have to give them a chance to ask, rather than just in one line you explain them everything. And make sure that you answer their questions honestly with patience. So let it be a dialogue where their questions are answered, and also they feel that their pain or their apprehension is being acknowledged. Number 3 is apologize. We have talked about apology in number of instances. We all know that apology does help. Sorry work, and there, of course, personal regret, rather than saying that it was my resident who did this, it was my nurse who did it, or it was a new nurse or a new doctor. I'm so sorry. So simply saying sorry, yes, this has happened, and I take the responsibility. That really works well. Taking responsibility, like Dr. Som was just now mentioning, and Ravinder also said, it could have been one of your staff members who has done it. Shift, rather than blaming them or shifting the responsibility on them. If you take responsibility, I think again it disarms the patient party. So don't blame or speculate, or don't try to justify what has happened, but take responsibility of what has happened. Inviting question is a very good way to make them talk. So when you say, what questions do you have about what has happened? That will show their concern, and also it will give you an opportunity to address those concerns. So it could be about money, it could be how long the patient will have to stay, it could be about the damages that has happened, it could be about recovery, it could be anything they may have. So one by one, I think we will have to answer those questions so that their concerns are addressed, and they go back well informed about what has happened and what is going to happen. At this point, making a follow-up plan with the patient party. For example, the patient is in ICU. Now, maybe they want to go and see the patient. Maybe they want to know what is the status, or maybe they want you to talk to one of their family doctor or somebody who is a doctor. So all that has to be sorted out how they want that to be managed. Also, they would want you to be available to answer their call. So in those situations, saying that I am not available, I am going, and somebody will be there to answer you, please, you will have to evaluate how you need to handle that. But it's important to first of all explain them, know what steps you have taken or you are going to take to minimize the damage. Maybe you need to go for a second surgery, so you will have to inform them that we will have to operate, for this reason, or whatever kappa you are planning, that you will have to share with them. Whatever needs they come up with, you will have to discuss with them and see how you can meet those needs. Like I said, that they may say that we want you to talk to one of their family doctors. So maybe if that's going to work for them, you will have to speak to them. And then, of course, they would want, how will we know what is happening now? So you will have to really plan for the next update. You may be saying that, okay, I'm going to see the patient and I'll let you know the status, as soon as they get some information. Or maybe you can say that maybe in an hour's time, somebody from our team will talk to you and explain it. So you'll have to really keep them in loop and let them know how frequently you are going to update them, because they will be concerned, especially condition is something very serious. So they would like to know minute to minute what is the condition. And of course, in case if there is some deterioration that needs to be communicated to them, then we'll have to do it maybe even minute to minute. And then, of course, as I said, remain accessible. That's very important. A lot of time when we switch off our phone or we refuse to give our phone number, they feel very agitated with other. So in those moments, we'll have to evaluate whether giving the phone number and letting them know that they can call you and talk to you and discuss. It's your call, but that definitely helps. After all that, it's very important to document the incident. So make sure that you report the incident that happened and the actions that you have taken. You will also have to give rationale for the clinical decisions that you took in this situation. So whatever you did, whether you operated or not operated, you whatever treatment you gave, you will have to document all those clinical decisions with the rationale. Then whatever was the clinical outcome and what further plan of care are you planning, that needs to be briefly mentioned so that it shows that you are in the know of what you have done and what you are planning to do. Then what discussion you had with the family, especially who was there with whom you talked, what was the relationship of that person, so that you can say that the family was informed and updated, and whatever questions they posed and how you answered that, all that needs to be documented, of course, with your signatures and your details and contact details. After the situation is over, it's very important to sit and reflect. I think after every such strong emotional encounter, I have always said, sit and reflect, because that's where our real learning lies. So make sure that you sit back to self-check in how you felt in the situation, what were the emotions, what were your concerns, what was bothering you, what really upset you, how are you feeling now, how is this affecting you. So all that will give you an opportunity to see how you are processing the whole episode. It's good to always discuss with colleagues with whom you can share your experience and share your feelings also, and learn from their experience, how they are dealing, how they have dealt. So a lot of learning happens when you discuss with your colleagues and learn from them. Reading material, as usual, is a good way to update yourself. Attending programs where you learn how to do crisis management or more, handling aggressive patient party. So these programs give us an idea how you can handle it. Of course, ultimately one has to do it oneself, but then these ideas give you some kind of guidance that help you to be better prepared. So this is in a nutshell about how you go about handling a situation like this. So quickly summarize. Uh, as I said, prepare yourself how you are going to do it. State what happened simply. Apologize. Take responsibility. Invite questions. Make follow plan together. Make sure that you document and you reflect. So these are a few steps you keep in mind. Hopefully that will help you to deal with the situation completely like this. Thank you. So I have two videos to show you. So again, these videos have been done by Indian doctors. You'll be able to relate with them. Majorly, what I want you to focus on is the way how to go about doing it. So let's watch the video and then maybe we'll have further discussion. So the first video is how normally we do it, and the second video is how we can do it in a more effective manner. So give me a second to show you the video.
Who's with Mrs. Kumar? I'm Mr. Kumar. Yes, hello. I remember meeting you earlier in the OPD. This is Mr. Girish, my brother-in-law. Hello. Please sit down. There are a few things I'd like to discuss with you about the operation. I'm afraid I have some bad news. We ran into some complications early into the surgery and we've had to shift Mrs. Kumar into the ICU. What happened? What complication? Oh no. Is she going to be all right? Well, she lost a lot of blood during the surgery and we couldn't realize where the bleeding was coming from. So we've had to open her up and it took us some time to find where she was bleeding from. In the meantime, her blood pressure was low and we've had to give her a lot of blood. Finally, we managed to control the bleeding. This was supposed to be a simple, routine operation. How can this happen? Well, Mr. Kumar, you remember the 1% bleeding complication risk that we spoke about? Unfortunately, Mrs. Kumar has had bleeding. We're doing everything we can to help her. We're giving her blood and IV fluids to support her. So now we have given the blood and bleeding is fixed. She's going to be okay, right? Well, she's lost a lot of blood and her blood pressure was low. So we don't know how long she'll take to recover. We'll just have to wait and see, watch how she does. What do you mean? Well, we just have to wait and see how she does. She's going to be okay, right? When can we see her? The ICU doctors are working hard to stabilize her. At the moment, she's not stable, so you can't see her, but we'll let you know. When she's stable, you'll be allowed to see her. I don't understand. This is supposed to be a simple procedure.
So since we have talked a lot about handling such situations, what do you think was inappropriate? Write in the chat box. What all do you think was inappropriate? Casual attitude, absolutely. Lack of assurance, absolutely. No preparation. He just informed and left, did not give hearing to them. Body language, tone, no preparation, swift exit. Doctor was not polite. Lack of empathy, absolutely. Have I missed any point? It was a public place. Yes, Anandita, correct. You're right. And then lack of private space to discuss, use of medical jargons, lack of apology, lack of empathy, walking away, absolutely. Publicly discussing and no ownership, absolutely, very right. Fabrication, likely. I don't know. Fabrication, I want to understand from you. 1 second. And then, of course, he appeared arrogant. Yes. Ending without properly answering, actually. No chance for asking. I think spot on. Yes, just like a routine information he's conveying. Absolutely. I think we have been able to identify almost everything that was not appropriate. Ignoring relatives' concern, not taking responsibility, not discussing further plans, and continuity of care. Absolutely. Lack of empathy. Absolutely. I think all of you have covered almost everything that I had on my mind. He was communicating in a very mechanical manner. He didn't see the impact of what he was saying to the patient party. I mean, you may have said that it's a simple procedure. A lot of time we say it's an OPD procedure. And then patient lands into some kind of complication, and then it becomes very difficult to explain them that you were saying it's an OPD procedure. I remember one of my known to, she had to undergo, cholecystectomy. So she was a young patient. She had, I think, 2-3 years old child, and she wanted to see her child before going for surgery. And the surgeon said, "Oh, it's just half an hour. By the time your child will come, you will be out of the OT. Don't worry." And she went. Unfortunately, she had some complication on table, went into coma, and she died. I mean, that's the risk involved when you make such promises. Then you don't know where you might land. So you saw this casualness, no empathy, rudeness, open place, not addressing, especially if there are two people and both are closely related to the patient. You will have to handle both of them. You can't say because I know you and I don't know him, I'm not going to talk to you. You will have to see that you are able to engage both of them and you ask a fair question. And then he said, I don't know. Even if you don't know, I mean, there's a way to say that, honestly, I don't know right now what is the situation. We are managing, we are trying to stabilize. I can only tell you when things really, are visibly okay. And more than that, I think your tone of voice, your body language, your connection with them plays a very big role. So let's watch the second video. Could he have done in this manner? And see, these doctors who were doing this role play, they are not actors, they are real doctors. but they have done excellent job in doing these videos. I really salute them for their acting and the way they have done it.
Who's with Mrs. Kumar? I'm Mr. Kumar. Hello, I'm Dr. John. I had met you earlier in the OPD. I don't believe I've met you. I'm Girish, his brother-in-law. Hi, Girish. I'm Dr. John. There are a few things that I would like to discuss with you about the surgery, but I would prefer that we do the discussion in a more private place. Is that okay with you? Okay. Please come. Fortunately, I have some bad news to share. We've run into some complications into the surgery and we've had to shift Mrs. Kumar to the ICU. What happened? What complications? Oh no, is she going to be all right? I understand that this is not news that you expected to hear, and I'm very sorry about this. There is a lot of information that we have to share with you, and please feel free to stop me if I'm going too fast or if you need any clarifications. Now, Mrs. Kumar had some bleeding early on in the procedure, and we did not exactly find out where the bleeding was coming from. That's the reason we had to open her up, and it took us a long time to find where she was bleeding from. In the meantime, she lost a lot of blood and her blood pressure was low. And eventually, we did manage to find the blood bleeding point, and then we thought we have to shift her to the ICU to monitor her blood pressure. But this was supposed to be a simple operation. How could this happen? Well, in order to do this operation, we first have to put a needle into the abdomen to build gas before we put the camera in. When I put the camera in, all I could see was blood. I could not see where the bleeding was coming from. And that's the reason I decided to open her up. Where did the blood come from? The bleeding was coming from a major artery inside the abdomen, and it appears that the initial needle insertion was responsible for the bleeding. Who put that needle? I put the needle in, and I'm very, very sorry about it. This just was not expected. We are trying our best to minimize the effects of the bleeding. Is she going to be okay? I wish I could tell you, but it's too early. I just don't know. I certainly hope so. She is on life support medications right now, life support systems for breathing. She is getting blood to keep her blood pressure up and powerful medications to keep her blood pressure up. We're doing all we can. When can we see her? Well, the ICU doctors are working hard to stabilize her, and as soon as she is stable, we could see her. I will let you know. Do you have any questions for me? Really don't know what to say here. I can understand that. If there are any questions, please don't hesitate to ask. In the meantime, I'm going back to the ICU. I will keep you updated on her status. Is that okay?
I'm sure most of you must be wondering what was the need to tell that I was the one who put the needle in. That's your call. That's your call. And also, it was not an error, it was a complication. That's a documented complication. But from the patient's point of view, some damage has happened to the patient. Whether it is a documented complication or it is procedural failure or whatever you want to call it. It's a blind procedure, so we all know that there's a possibility of this kind of complication. But the fact that I want you to focus on is the tone of voice, the body language, the way he spoke, the way he answered, the way he made them comfortable, and also how he made the plan that I'll keep you updated. That's what I wanted you to focus on. So, any questions about the video or the PPT that we have discussed this evening? Everybody is in thinking mode. Okay, if no more questions, although I think we have discussed a lot, so we have some idea. See, no program can completely prepare us for something like this. But at least some idea that yes, this needs to be dealt in this manner. And if we work on it, we can enhance our skills to, slowly learn how to handle difficult conversations. That was the whole idea about this program. It's only practice, practice, practice. First of all, when we are handling people, we need to practice these skills. And then, of course, when you will train people, you will also automatically enhance your learning. It's a mutual, learning from each other. So this brings us to the end of the topic and also end of the program. We have, I think, 2 presentations today. Dr. Bijoy and Ms. Jenna will be presenting. Anybody who's left with the presentation? That means all have completed. Am I right? Okay. So I'm just changing the setting to share screen. So Dr. Bijoy, will you make the presentation first? Okay. So I've changed the setting and you can share your screen and introduce your topic.
Am I visible, ma'am?
Yes, you are visible.
Shall I start?
Please.
Abu.
Good evening, all. So, my topic of presentation is basic guidelines for PowerPoint presentation. We have been doing a lot of presentations lately. I think it's a bit late to present this because this was something it's supposed to be presented in the first part of our program, but still, Madam was very particular to take this presentation. So, as per her opinion, I'm taking this presentation. Don't worry, there is a number of slides, but it's just simple points. Majority of the things we know very clearly. I've just kept those things in a slide. That's all. So it's about making a PowerPoint slides, and it's actually avoiding the pitfalls of bad slides. We are covering the whole topic in some 9 points. It's the outline, slide structure, fonts, color, background, graphs, spelling and grammar, conclusion, and questions. Outline. Make your first or second slide an outline for your presentation. And follow that outline for rest of the whole presentation. That's the best thing to do. And only place main points in the outline slide. Use the titles of each slide as main points. Slide structure must be very good. Use 1 or 2 slides per minute for your presentation. Write in point form. That is the most important thing, not in complete sentences. Include 4 to 5 points per slide. Avoid wordiness. That's the thing. Use keywords and phrases only instead of writing a lot of statements over there. Below is an example of a bad slide structure. This page contains too many words for this presentation. Actually, this is the same as the points which I mentioned in the previous slide, but it looks much more complicated. In short, the audience will spend too much time trying to read this paragraph and instead of listening to you, and that will be bad for the presentation. So it's an example of a good and bad slide structure. Way too long for a regular presentation. It's been there on the right side, and a good presentation, title presentation, is in the left side. A good slide structure will show one point, will help audience concentrate on what you are saying, will prevent audience from reading ahead, and also it will help you to keep your presentation more focused. So below is an example of a bad slide structure. And it's always better not to use any distracting animations. And we cannot go overboard with the animations. And also we are supposed to be consistent with the animations
which we are used. So regarding the font type, at least an 18-point font is always advisable. Use of different size fonts for main points and secondary points. Better it is running font is 24 point, main point font is 28, and the title font is always minimum 36 point. And mostly standard fonts like Times New Roman and Arial is always advisable. These are some example of some good and bad fonts. The issue with the wrong font is that it's almost many times impossible to read. And the better one, this is a lot easier to read. So your audience will think the same. So also bad fonts, these are some example. If you're using some small fonts, your audience won't be able to read what you have written. And using of capitalizing is also only where necessary. Otherwise, it's difficult to read also. And also, it's better not to use any complicated font. Fonts example, right font size. Some people use text that are too big and some use text that are too small, and it makes it difficult to read. The right font size is always better. Presentations are actually aimed at for an audience that have ordinary eyesight. Relevance and quality of images. Usually, our text is supported by a low quality images. Images tend to be illustrations and drawings, making our presentations look unprofessional. Make sure you select high quality images that support your message. So these are some examples of quality images. You can just see it by yourself, no need of any explanations on this. And regarding the color part, use some color or fonts that contrast sharply with the background. For example, blue font on white background. Use color to reinforce the logic of the structure and your content. Light blue title and dark blue text. Use color to emphasize a point, and you can use it only occasionally. So regarding some bad colors, you can see some examples on this. Using a font color that actually does not contrast with the background color is pretty much hard to read and comprehend. Using a color for decoration is always annoying and distracting. Using a different color for each point is unnecessary and unwanted. Using different color for secondary point is also unnecessary, and also trying to be creative can also look bad. Color example, text on image are usually not legible. So you have to keep this in mind while making a PowerPoint presentation. Text on image are usually, you can have an example on this. Background, use backgrounds such as this one that are attractive but simple. Use backgrounds must be light, and ideally the background must be consistent throughout your presentation. So these are some examples of bad backgrounds. Avoid backgrounds that are distracting or difficult to read from, and always be consistent with the background I used. So regarding the data, use graphs rather than just charts and words. Data in graphs and pie diagrams is easier to comprehend and retain than is raw data. Trends are easier to visualize in graph form. And always remember to title your graphs. Showing data is an example of good data, right and wrong. Regarding some smartphone usage, you can just see it by yourself. And regarding spelling and grammar, proof your slides for spelling mistakes. Use of repeated words must be avoided. Grammatical errors you might have made. Even you can find 2-3 spelling. Spelling 3L is the of 2 repeated words is the. Also, there is a grammatical error in this statement. Grammatical error you might have made, it needs to be kept here. So first of all, if English not your comfortable language or first language, feel free to check your presentation and to proofread your presentation. So these are some deadly sins which I can make out regarding making PowerPoint presentations. Slide transitions and sound effects, standard clip art, some presentation templates, text-heavy slides, reading, faith in technology. And regarding faith in technology, I like to add is that in the artificial intelligence era, there is a lot of websites who just give you a topic, they will come out with a lot of presentation. So making a PowerPoint presentation is a lot more easier nowadays. But it take away the soul of the presentation. So if at all you are using the technology and art AI part, you have to make it, you have to be very careful. So conclusion, use an effective and strong closing. Your audience is always likely to remember your last words, and use a conclusion slide to summarize the main points of your presentation and suggest also some future avenues of research. Also, you can ask about the questions. Always, it's nice to end your presentation with a simple question slide, and always invite audience to ask queries. Provide a visual aid during question period and avoid ending presentation abruptly. Thank you.
Thank you, Dr. Bijoy. Can you stop sharing your presentation?
Yes, ma'am.
Wonderful. Excellent presentation. I think everybody is writing excellent for you. Very well covered. I think these are the points we have to keep in mind when we are preparing our presentation. That was the idea. See, PPT everybody makes, but then sometimes we mismatch the font and color and combination. So your presentation is spot on. See, everybody is complimenting you for the excellent work. Thank you. Thank you. Any questions for Bijoy?
No, actually, ma'am, I like to add, actually, I made another presentation before I was sending to you. And I took some help from these websites, some AI presentation, PowerPoint website. I made 2-3 days. And I was more onto the concept of this PowerPoint presentation, and I made you to that. So a lot of philosophy was there in that. A lot of interesting the charts and interesting pictures were there. I was so happy to it. I sent that presentation to you. Madam, simply point blank, I want you to make it so simple. I want you to give some example of bad slides, good slide about the font, text, and all. That was an eye opener for me. And fortunately, I got this presentation. So, I mean, I managed to make this, managed to get this one. So, I'm also happy that it worked.
See, the whole idea is that we all should be able to make good presentation. Simple, to the point, with least number of words, and not too much, worded like you have mentioned. So I think you have covered almost everything about color, contrast, font size, number of words, lines. That's what I wanted to be covered in this topic. And you have done an excellent job. Thank you. She had already made a presentation ready. And I said, sorry, this is not the presentation I want you to make. So you'll have to make another one. But nice that he put in efforts and he made fresh presentation once again. Thank you. Thank you for taking my words. Thank you. So any questions for Dr. Bijoy from anyone? No, I think it was very well explained. Okay, then we have presentation by Jenna. Are you ready?
Good evening, everyone. Am I audible? Can you see the screen?
Yes, we can. Yes.
Yeah. Let me take you all to Goa, to my hometown, basically. Imagine you're in Goa and on a beach at Bagmolo. It's about 5 minutes drive from the Goa Daboli airport. We are on the beach. Let's go there. Have a seat on the beach. Imagine, visualize things. Can you feel the sand under your feet? Can you feel the water? Can you see people enjoying in the water? Can you see the ice cream carts? Can you see people playing? Please visualize. See what you can see. Imagine. Do you feel the water? Do you feel the breeze or the water on you? Can you see the waves? Or when you think about Goa, Do we see something like this? What do we see?
So Jenna, are you supposed to be moving the slide, or
Yes.
it is?
I'm talking about visualization.
No, you are on the first slide. Your slides
Yes,
are not
yeah,
moving.
yes. This is my first slide.
Okay.
I was just imagining, I was visualizing things on the beach,
Yeah.
what I could see, or what all of us could imagine, visualize there. My topic is on visualization in learning. As you see, visualization is a powerful technique that can help improve.
Jenna, can
our
I stop
learning.
you?
Yes, doctor.
Your slides are not moving.
No?
No, that's what I'm telling you. We are stuck on the slide 1. Either you move to slide show first of all.
Doctor, 1 minute. Slide.
Yeah.
You're on slide 1. Is this a slide? Slide 1?
Only slide 1. Your slides are not moving. Plus, you have not, started with the slide show.
Doctor, can you all see now?
It's only on the first slide. We are stuck on the slide 1.
Slide. Do I go to slide
You need to
control
go
now?
down and, where it is written 69%, with that there's a cup sign. If you touch that cup
1
sign,
minute.
you will go.
69%.
Yes.
Okay,
Now we are
okay.
on slide 2, but then it is not slide show. Yes.
Okay,
Next.
I'm
This
on
one.
Yeah,
This
I'm
one.
on that.
No.
I'm on that, doctor, right now.
You touched just now, but it hasn't yet started. Yeah. You have made it 100%, but it is not slideshow.
This is the one, right?
Slideshow? No, you have to touch this cup button.
Yeah,
with
cup button.
100.
Yeah.
Click on the.
Is it now?
No. Or you can go on the top, on the first blue bar on the top.
I'll go
And
to
with
end show.
animation, it is written slideshow. If you can go to slideshow. No, further. On right. Yeah. Next.
It's
Move
mute.
further. No, not this one. No, not this one. Slideshow on the first blue bar. After insert, design.
Or that other mute thing is coming. The screen share is coming actually.
No, that is done. After below that. Yeah, you are on insert.
Yeah.
Then go to design. Go to animation. Move further right. No, not this one. Yeah. There are multiple options.
Yeah,
no? Yes.
yeah, but this is not moving the thing on top.
Okay, then it's okay. Then you keep just moving this slide as it is.
Like
It is
this?
on. Yeah, it's
This is
okay. Go
okay?
ahead.
This is
Yeah.
okay?
Fine.
You can see it like this?
It's not fully visible, but then it's okay. I think there is some challenge at your end, maybe. Yeah,
Okay.
go ahead.
Okay, I'm going to talk about visualization as a pedagogy.
Sure.
Visualization is a powerful technique that can help to improve our learning. It can help us create strong mental image of a future event. It involves creating mental images of a desired outcome processes that we want to achieve. It can enhance our confidence and efficacy as it allows us to rehearse. Visualization can also be used to practice in advance an event so that we can prepare properly for it. This pedagogy can be used at one-to-one level, group activity, teamwork, sports, students, interns, even in meditation and relaxation techniques. Advantages of this pedagogy: it makes growth visible and motivating. It helps us understand and remember information. Because when you visualize things, when you create images in your mind, you know exactly what you are trying to remember, what you want to do. It helps improve feedback and reflection skills. It facilitates problem solving and decision making. Images and pictures are easily remembered and connected. Disadvantages of this visualization pedagogy is, it can be difficult or uncomfortable for people, especially if they have a low esteem, negative self-talk, or anxiety. It can be unrealistic and unacceptable if you lack information, experience, and feedback. Do's and don'ts. You have to choose the right type of visualization. Declutter your visualization. Focus on getting the attention of your audience. Think like a designer, creator, achiever. Practice and improve. When you practice and improve, you can present better, you can remember better. Focus on what you want and not what you don't want. Focus on positive feelings. As visuals can mean different things to different people. Like we were on the beach right now. Maybe I was thinking of the sand and the water. There was somebody who was sitting there with me thinking about the visualizing people playing, or maybe getting their family across, visualizing things, something like that. Lack of focus can make your visualization confusing, vague, and inconsistent. Lack of emotion. It can be boring, uninspiring. Don't just create a plan, you need to work on it. You have to make it happen. Lack of feedback can make your visualization inaccurate and ineffective. Lack of flexibility can make it outdated and irrelevant. This is just a picture of when you try to use your brains and try to visualize wherever you are, wherever you're standing, maybe in a classroom, or maybe on your own, or maybe at the beach, or a hill station, or it can be anywhere. It can give you lots of ideas when you try to visualize something. Thank you. I'm sorry I could not present the slideshow properly. Doctor, I'm sorry I couldn't present it. I don't know why. I was not getting it.
That's okay. That's all right. I
I
know
was not getting it.
you're still, slowly becoming comfortable with technology. So no problem. Don't
No,
worry.
it was I was doing it, but not showing it at all. I don't know why. Thank you.
Thank you. Can you please stop sharing?
Yes,
Yeah.
yes, doctor.
Thank you.
Yes, doctor.
So thank you, Jenna, for an interesting topic that is creative visualization. That's a very good way to engage your audience, especially when you want them to seriously reflect on a situation or to visualize something in future. So in neuro-linguistic programming, we use visualization to kind of crystallize your plans or programs very extensively in very great detail. We use it. So I remember when I was doing this master program for NLP, I said I want to write a book, and it took me through all steps on how am I going to do, what I need to do, at what time I need to do. So more clear I was what steps I need to take and when I need to take. It gave me more concrete plan of action. So there it is done very systematically, but that was a very beautiful way to take us. Like if you remember, in understanding patients' expectations, I took you to your hospital OPD just to get you connected with the reality. So it's a very good way to create empathy with others. It can be used extensively, even in emotional intelligence, when we talk about identifying emotions and regulating emotions, and also understanding the impact of our behavior on others. Visualization is a very powerful tool in helping people reflect on their behavior or their expressions or the way they handle situations. I use it very extensively in my programs. Thank you, Jenna, once again for the presentation. Any questions for Jenna? Are you all using visualization as a tool? No, not
Yes,
yet.
we are.
Ravinder, you are using. So in what situations do you use, Ravinder?
It is mainly, when we have to talk about certain clinical situation in the classroom, we talk about that. Imagine that you are with a patient and this is a situation, how you're going to deal. Many times you're doing like that. We take them, creating like a story sort of a thing.
Good, very nice. So with this, we come to the end. Before we close, I would like, I know we are past 10, but another maybe 15 more minutes, if you can bear with me. I want each one of you to give your feedback about what has been your learning or whatever you want to say about the program comfortably. So who would like to start? Raise your hand. Okay, Dr. Abhishek. Go ahead, please.
Good evening, ma'am. Good evening, everyone. And I just want to thank you, madam, for creating this program because it's one of its kind. In medical schools, we are never ever taught communication. We learn on the go, and most of the time, we are not learning it. That's the truth of it. If we get a very good mentor, we pick up bits and pieces because nobody sits and tells you what you need to do. It's just we observe and we do it. If it's got a bad reaction from the patient's relatives, then we think, okay, we shouldn't do it. If it finds a favorable reaction, we start emulating the same grammar, the same tone, and the same sentences, and we start copying it later on. So this is a one of its kind thing, and it's been an eye opener for me to reflect on my prejudices and the areas where I'm lacking. And I will also like to say it has been designed in such a methodical manner, taking us from the beginning to the end, covering all the bases, covering all the scenarios, and involving role plays and other modalities. It just makes me feel that if there is going to be a challenge in my professional practice, I can always look back to this and take a lot of courage and understanding from it. So thank you so much.
Thank you so much, Dr. Abhishek. I think you have been an excellent participant because all through you were quite, attentive and participative. I think that's what is expected. Nobody can teach anybody anything. It's only through your participation you learn, by discussing and talking. But you have been an excellent participant. Thank you so much for your kind words. Thank you.
Thank you, ma'am. Thank you.
Thank you. So I think next we have Anandita.
Good evening, ma'am. As I start, in the beginning only I told how time flew. I didn't realize it was such a wonderful time. I used to really look forward for these 2 hours, wherein I got a chance to be a student after a long time. That kind of feeling I had started developing. I've started thinking as you as my mentor. Although I am from a non-clinical background, but so many things I learned, and always the other side of the grass is not always green. So it is very difficult to handle. I mean, we used to think uh, whatever impression we had, now it is totally. I mean, now I can also empathize how doctors and other clinical staff, it is difficult for them to handle, and how communication plays a very big role. This entire episode of all the 10 sessions that we have was very engaging and very absorbing, fascinating throughout. Never I lost my concentration at any of the session, and wherein I had a lot of self discoveries and a lot of takeaways I'm taking away from after this session. The best thing I enjoyed, ma'am, was the conflict management style, and I realized what is my dominant style and what best can I do to maybe, and what are the appropriate steps that I can take actually. So I can now correlate, every day, whatever communication is taking place, I keep correlating. Okay, ma'am said this. So See, I just keep telling to myself, this is an example, bright example of whatever you have mentioned in one of the classes, sessions, whatever. Thank you once again for the excellent session, ma'am. I thoroughly enjoyed. Thanks.
Thank you, Anandita. You being such a seasoned and experienced HR personnel, attending the program with great dedication and sincerity, I think that speaks volume about you. And you saying that you took away, these learnings and you're going to implement this in your, day-to-day functioning. That gives me a lot of satisfaction. That I mean, I'm adding maybe a drop in the ocean of the work that all of you are doing. I'm so grateful to you to have attended the program with so much of sincerity. Thank you so much. Thank you. Thank you.
Sure, ma'am.
Thank you. I think Dr. Purnima wants to speak. Ma'am, please go ahead. Yes.
A very warm good evening to all of you, mainly to Dr. Indu Arneja ma'am. Today is the last session of this coaching, which had become the high point of my life for the past few weeks. After having spent nearly 3 decades in a mixture of clinical services and administration, I always knew the importance of communication, mainly in the field of pediatrics. And I used to try and practice the best communication, but it was only based on trial, error, experiences, and I tried to get better with it as my role evolved and as my position changed. I should really thank this course for giving me a very structured, organized framework with which we can really incorporate good communication in different scenarios. All the different learning teaching methodologies were such an eye-opener. I have walked away from this course not only with the knowledge that you have added, but from 2 more valuable things also. One is the connect with this very nice peer group. I think I should be the oldest in this group. So it has been very nice to meet all this peer group spread far and wide, and I hope we maintain our connect. And most of all, I value the fact that I found a very good mentor and an inspiration in Dr. Indu Arneja ma'am. Thank you, madam. And I hope our professional and other associations continue.
Absolutely. Thank you so much, Dr. Purnima.
Regards to all of you.
You really, took interest in attending the program. I know you were supposed to join the last batch, but I think at the last minute you had some concerns. So thank you for joining the program, and you have been one of the bright students of this program and bright teachers of this program, because we all learned from your experience and expertise. I think that has been the beauty of this program. All of you come with so much of rich experience that I alone could not have taken you through this program. It's only because all of you came forward, shared your learning, shared your thought, and you open to learning new things. I think that was the most beautiful experience that I had with all of you. Thank you once again for being there, for attending the program and contributing. Thank you.
Yeah, just I will also like to add. Yeah. Can I?
Yes, Raminder, please go ahead.
Yeah. See, we had been in nursing, we had been talking a lot about communication, especially in mental health nursing. We give a lot of importance to that. But going through this journey, especially with such a diverse group from different background and, the experiences which were shared, that was a wonderful experience. And the role plays which were there, and, the way one of the difficult thing that I also had written in that is how to talk about the medical errors. And I was put up in that situation. So that also gave that experience. So, I was thinking that I was the one who had even written about, but it was wonderful experience. I'm just giving one example, but all the role plays and the different methodologies which were used, different pedagogies which were used, they were very useful. And we have really learned from each other, definitely from you the most, but with each other's experience and the way you had taken up such cases, taking up from the group only and discussing was wonderful. Thank you so much.
Thank you, Raminder. It was pleasure having you. I mean, you with so much of experience in the background, you coming and attending the program itself is it's an honor to the program. Thank you once again. Thank you. God bless you. So anybody else who would like to speak after Raminder?
Doctor, can I say something?
Please, Jenna, go ahead.
Yeah. I think actually Mrs. Kalraoli was the one who told me about this program, and we said, okay, why not? We do it together. Um, okay, I had a lot of problem with my computer getting connectivity in the beginning, but then I did go through the slides. When the program was over from the mobile. But there was a lot of learning, and we had experts like along with you. We had Dr. Purnima with us, and then we had Dr. Som with so many of his experiences. Dr. Bijoy about his experiences, Dr. Abhishek, Dr. Anit, all of them, Dr. Anit, Dr. Anu, Dr. Apanna, everybody were telling about their experiences. So it's always a something what we learn, and I think what I learned was basically listening, communication, and listening part of it. Normally I do the talking, but I think I got to listen more now, and that's required for me. I think as a HR person, listening is more required, and obviously how to communicate and what is the other person's point of view, and it was summed up by everybody in the group, and I learned something from everybody. You are the main person, but I did learn something from somebody, like all who are present here. It was a nice experience, and we go from here with lots of learning. Thank you, Doctor. Thank you so much.
Thank you, Jana. Thank you. I think it was everybody's contribution that made the program so lively and useful for everyone. I think you have said very rightly, having such learned people in the group itself, adds value. Thank you once again, Jana, I guess. Yes, Dr. Som, I think you wish to say something. Please go. Yes.
Thank you very much for this program. I think the training sessions were all exceptional, I would say. I think your expertise in communication skills have shown brightly. Rather than teaching us communication skills, you lived by the communication skills for all of us to observe and learn from it. That's a very good thing, because I think you walked the talk. So I think that was a good thing which I have learned. And then your engaging style was something I would always appreciate, and I will always, I think I would take that as yeah, it's an inspiration for me that you engage and you created a supportive learning environment for all of us. So some of us are introverts, some of us are very eager to participate, and then you just made sure everyone contributed, everyone learned and shared, and then that's a very wonderful thing that you gave a platform for everyone to present, so that they break their communication barriers that they may or may not have. So that was an important thing. And your feedback was very invaluable. I think they gave us some actionable insights. And I think they'll give some empowering, help us empower to improve our communication skills, especially when we do role plays and then asking what can be done better, or what was the thing that's lacking in such things. So I think that there was lots of subconscious assimilation of knowledge from each and every one of the presenters, those who have played role plays, those who have shared their experiences, and directly or indirectly there was some amount of knowledge was going in, and I think it was a truly outstanding program. I think without any deep understanding of the unique challenges and the complexities of the healthcare environment, this program will not be this successful, or it would not have reached that. I think you have struck the chord at that point. I think, and the one important thing I would like to appreciate is the way that you have tailored the program. So step by step, you have taken things in such a way that it encompasses all the major areas of communication needs in healthcare setting. So I think it's incredibly insightful, and I think I have learned a lot from each of these sessions. More importantly, the other one important thing I would like to appreciate you is your active listening skills and the listening techniques that you showed. That's as a communicator, not mere speaking is an important. Active listening just makes an important part of communication that you showed by living how one can be an effective communicator. That was a good thing for me to learn. The real world scenarios and the practical examples I think those resonated with my experiences. So that made this training program more highly relevant for me and much more engaging for me. I think you have equipped us with the tools and skills that are necessary for us to navigate challenging communication situations in healthcare with confidence and competence, I would say. So I think this program will undoubtedly have a very positive impact on all of us. And it will have a very good impact on the quality of care that we provide to our patients and our healthcare teams as a whole. And moreover, I think everyone of our team members would agree that not only in professionally, also in some personal relationships, these communication skills will help for every one of us. So thank you very much for this wonderful program. Thank you.
Thank you so much, Dr. Som. I think all these
Ma'am,
compliments.
can I talk?
Just 1 second. Let me thank Dr. Som. Give me 1 second. Yeah. So I was saying that I mean, these compliments, feedback, comments coming from Dr. Som, I think it's a great honor because you are already a teacher, trainer, faculty, such a senior consultant, and then you giving these feedback really, instills my confidence back into my work and motivates me to make it better every time. Thank you so much. I think your openness to admitting and sharing your learning and your thoughts, I think that made the program so beautiful for all of us. Thank you for attending the program with great sincerity. I can see today you're looking very tired. I can see from your eyes that you're very tired, but still staying awake, being there, attending the program with your camera on is not a small thing. But that makes everybody so committed to the cause that we all have to be here with each other for those 2.5 hours. Thank you once again for being here. Thank you.
Thank you.
Yes, Sibyl, go ahead, please.
Thank you, Dr. Indu Arnaja, for giving this such an opportunity to be part of this great team with a group of experts. Have learned a lot from everyone. And ma'am, the sessions were organized very nicely, like started from simple communication and have gone into more complicated things and last with the most difficult communication you have done with. And the concept has, a lot of concepts have changed in me, like how to communicate, how to reveal certain situation, in a difficult situation, how to communicate and those things. I have learned a lot. And also, I express my sincere gratitude to everyone because it has a learning experience and lot of sharing and group activities, everything enjoyed. Thank you so much from the heart to everyone.
Thank you, Simil. I think you have been one of the very, enthusiastic participant, always wanting to share and learn. I think your participation was excellent. Thank you for being here. Thank you. Thank you. Anybody else who would like to share their thoughts or feedback? Anu, would you like to speak? Let's know what have you learned, what have you enjoyed, anything you want to suggest to change, to modify.
No, ma'am. I have enjoyed a lot. Like it's clear, like peer learning was happened a lot, and working and staying and learning from this heterogeneous group is very nice. Like different experiences they brought. It was well taken, and I thoroughly enjoyed it. Thank you so much, ma'am, for making me to join in this training program, and met some good people and have some good friends too. So thanks a lot. That's it. Thank you, ma'am.
Thank you, Anu, for the feedback. And I think heterogeneity of the group has brought in more, information and knowledge sharing and wisdom sharing that has, taken place in the group. Thank you, Anu, for pointing.
Thank you, ma'am.
So, Dr. Razak, would you like to say something?
Good evening and assalamu alaikum to all. Actually, this is very like interlinked program, and I have come to know how to communicate with the patients. And actually, I came to know what is my weakness, and actually where I was and what was my fault, and in this program helped me a lot. I hope in near future it helps to recognize me in a new way, and helps to communicate with the patients and deals with some arrogant patients, and also taking bad news and how to deal with medical errors. Thanks, ma'am. Thanks, everybody.
Thank you so much, Dr. Razak, for joining the program from Bangladesh. And I don't know how much of this exactly fits into your healthcare delivery system, but at least it will open an idea of how you can modify it to suit your work situation. Thank you. So, Dr. Bijoy, I think you have already shared, but if there's
Yes,
anything.
ma'am. Yes, ma'am. I have already shared in the initial part of the session. So it's such a wonderful experience. And Dr. Som, Dr. Abhishek, and Purnima madam, they have all had the opinion which I feel almost consistent with. So I got a feeling of going back to my classroom with people of different perspective people with ma'am, you being the teacher, Purnima ma'am being the class leader, Som is the most studious guy in the first bencher. So I got a feel like that. And I always try to be the backbencher who always make the noise, make the fun part, funny type. So it was such an amazing experience for me. And as everyone mentioned, I learned a lot of things, not just the subject, a lot of things, how to deal with people, a lot of things. It's going to be helpful for me. And I hope, as you correctly mentioned, this team, this group will be continuing, and we will be taking tips from you with relevant things. And since being in Kerala, I welcome each and every one of you to my state. I think at some point of view, you will be visiting this part. So please, I'll be so happy if you call me and I can be of any help. So I just want to mention that also.
Thank you so much, Vijay. Thank you. So thank you everyone for attending the program with great dedication and commitment. That shows from 8 to 10:30. You all have been, doing this week after week, and how the time flew. There has been a very rich learning for me also, to have learned from your experiences, your, whatever we have done in our place to bring it on the platform like this is not easy, but you have all very generously shared your experience and expertise. Thank you so much. Wish you all the best. I'm going to share 2 questionnaires. One is post-training assessment and feedback. For feedback form, I can say a lot of you very religiously have not completed it. So if it's okay, I request you to complete the feedback form, to all of you, if I can request. And also the post-training assessment. These 2 forms I'm going to share in the group. I request all to complete them. Thank you so much. Good night. Bye-bye.
Thank you, ma'am. Thank you.
Thank you, ma'am. Bye. Bye. Let's
Bye.
hope to stay connected.
Yeah, thank you
Absolutely.
so much. Thank you, ma'am. Thank you, everyone.
Thank you.
Thank you.
Thank you and good night.
Thank you.
Good night.